there are several vaccinations that older patients should be up to date on. Those include Haemophilus, meningococcus, hepatitis A, hepatitis B, tetanus, diphtheria, pertussis, as well as measles, mumps, rubella. However, there are 4 that I want to focus on in today's session. The first one is the influenza vaccination. It's important to note, though, that overall I tend to recommend the influenza injection rather than the nasal administration, as the nasal administration contains a live virus, and patients with inflammatory bowel disease whose immune systems are suppressed, whether it be due to steroids, methotrexate, azathioprine, or even biologic therapy or small molecule therapy such as tofacitinib or Xeljanz, live vaccines are not recommended while patients are taking those therapies. So therefore, the injection would be preferred. Number 2 is the Copid vaccine. The Copid vaccine is extremely important, and as older patients with IBD and older patients who are immunocompromised, it is even more important that this patient population is vaccinated, not only receiving the recommended 2 doses, but as well the additional recommended booster shot, which right now should be administered roughly 14 to 18 weeks after the second COVID vaccine has been received. Number 3, pneumococcal vaccination. Pneumococcal vaccination is administered via Prevnar 13, which is the conjugate vaccine, and then 8 weeks later, the 23-valent pneumococcal polysaccharide vaccine is given, and this is repeated in 5 years to ensure ongoing protection. And lastly, would be vaccination against shingles. One is called Zostavax, the other is called Shingrix. Zostavax is a live vaccine, whereas Shingrix is an inactivated form of the herpes zoster virus. And so therefore, due to the issues with patients not being able to be vaccinated with a live vaccine such as Zostavax while on immunosuppression, the preference is often for Shingrix. Now, even when you compare the efficacy, Shingrix is far more efficacious than Zostavax. So Shingrix efficacy rates up in the 97% range for those between ages 50 to 69. When you compare that to the efficacy of Zostavax, which ranges between 64 and 70%, it's no surprise that Shingrix is the preferred vaccine method, if possible. And another point I do want to raise is that shingles is more prevalent, I would say, in the inflammatory bowel disease population. And age also adds an additional risk factor for shingles to occur. Therapies over and above that can also increase the risk of shingles further. So for example, tofacitinib or Xeljanz, which is a small molecule therapy currently approved for ulcerative colitis treatment, the risk of getting shingles on that treatment for people who are on the higher dose of 10 milligrams twice a day is for every roughly 20 patients treated, 1 can get shingles. And those that are on the lower dose of 5 milligrams twice daily, for every roughly 100 patients that are treated, 1 can get shingles. Therefore, I strongly urge you as a patient or as a practitioner to recommend the shingles vaccine for our patients.